Hello, everyone, and thank you for joining us today. And welcome to our webinar, Your PDPM Huddle Game Plan. Today, I will be your coach on establishing a daily huddle that yields an effective PDPM game plan. My name is Curtis Wetzel. I'm a DPT by trade, and I have been an area manager with TMC going on 2 years now. Before we proceed in today's topics, I want to first of all thank all of you for taking the time to join us today, as we understand your time is more valuable now than ever. Also, on behalf of TMC, I would like to thank you for what each and every one of you are doing on a day-to-day basis to keep our residents and staff members safe within our current environment. So the focus of today's discussion is how to revamp your current daily meeting structure for success within PDPM. As we know, we began PDPM in October of last year, but we continue to evolve and learn best practices to both improve patient outcomes and obtain reimbursement for all of the services that we provide. Today, we will focus on who should attend these daily huddles, how often we should discuss each patient during these huddles, what our key topics of conversation should be, and how to measure our success. So we'll begin with setting your lineup. The key to any successful game plan is establishing the appropriate lineup. In order to host an effective PDPM huddle, we need to know who should attend and what their role is. So beginning with the quarterback, the executive director or ED would play this position to ensure that all of the role players are completing their assignments, such as proper documentation and committing to their role within the plan of care. The MDS nurse would play the coach's role here to review what players' assignments are and ensure they are completing it effectively and timely. Within PDPM, respiratory therapists and nurses play a vital role in a patient's plan of care and should attend each meeting to understand the nursing needs with a focus on pulmonary treatment needs of each patient. The therapy director is essential to provide updates on the functional plan of cares for each discipline that correlate to the specific resident. The dietitian should be in attendance to provide any information on diet modifications, as well as patient preferences, as nutrition is a vital component to recovery. Social services should also be in attendance to assist in reviewing the patient's depression screening, cognitive screening, and DC plan in order to assist the interdisciplinary team in establishing a good prognosis. Once your lineup is set, it's time to develop the game plan. The first step to this is having the MDS nurse share what primary and secondary diagnoses will be utilized to drive payment. This will allow each discipline to tailor their specific plan of care to the patient and make commitments to documenting services that are rendered. Social services should also share, as we previously mentioned, the cognitive and depression screening information in order to inform the team on what emotional and mental status the patient is in. These two screenings also have an impact on reimbursement, so reviewing them as a team is essential because patients' emotional as well as cognitive levels can fluctuate, specifically within the first few days of entering a skilled nursing facility. Section GG scores from both nursing and therapy should be reviewed in order to compare what was obtained and provide the most accurate representation of the patient's functional status. Again, this is an essential piece to review because a therapist within the first 3 days may only spend 1 to 2 hours with a specific patient, whereas nursing and CNA are spending all days with the patient, and as we know, functional status can change from day to night and day to day as well. Therapy utilization plans should also be discussed, including what discipline will be involved in the plan of care and what deficits they are addressing. This can often uncover patients' comorbidities that are not initially discovered, such as swallowing and cognitive deficits. When we review therapy utilization in a little bit more detail, I'll discuss this further. Finally, the patient's desired DC destination should be discussed, as well as alternative DC destinations if the prognosis does not correlate to returning the patient to their prior level of function. Once the diagnoses have been determined, each discipline should commit to what documentation they will be providing to support this treatment. For example, if respiratory treatments will be provided, the nurse or the respiratory therapist will need to acknowledge their commitment to document these services in order for the MDS coordinator to claim this on the submission. For example, with these, if we're providing treatments such as nebulizers or checking O2 stats, the nurse that is responsible for documenting that in the chart, or if it's the respiratory therapist, must acknowledge this within this meeting so that the MDS coordinator can be comfortable to claim it on the submission. This brings me to how often each patient should be reviewed in our PDPM huddles. We have become accustomed to reviewing an admission on day one and moving past them until the weekly update meetings. This routine must discontinue in order for us to be as successful as possible under PDPM. Each new admission should be reviewed daily from day one until the ARD date to ensure proper documentation is being completed and that there have not been any new deficits identified that may affect both payment and treatment strategies. Some key examples of mistreatment and reimbursement opportunities due to either lack of interdisciplinary team communication or lack of documentation are respiratory therapy services as well as restorative therapy services. If a patient has a diagnosis of COPD or has shortness of breath while laying flat, the opportunity of providing respiratory treatments 7 times a week for 15 minutes presents itself in order to give a possible increase in reimbursement of $80 to $100 a day. This is easily accomplished by ensuring sufficient documentation is provided in the chart daily by either nursing or the respiratory therapist pertaining to things such as delivering nebulizer treatments, checking O2 saturations, and assessing lung sounds. Again, that needs to be documented for 15 minutes a day for 7 days in order to be claimed on the submission. Although the utilization of restorative services in combination with therapy under PDPM is to ensure that all therapy time is utilized for skilled interventions, it can also provide an increase in the average daily rate. In order to do this, it must be documented appropriately for those patients who fall in the behavioral symptom or cognition category or the reduced physical function categories. An easy way to audit potential patients who would have qualified for reimbursement with restorative treatments, which must be delivered 5 times a week before the ARD date, and it must be delivered with 2 qualifying programs, which can be found on CMS's website as far as which programs are qualified. And in order to audit this, if you find any patient that falls in a nursing category that starts with a P or a B, such as BAB2 or PDE1, you know that you had the opportunity to capitalize on this. As we know, Section GG is now a component that can affect reimbursement. It is also a key factor that provides information on establishing an appropriate plan of care for each patient. This should be reviewed by the interdisciplinary teams on days 1 through 3 to compare what both nursing and therapy have scored each patient in order to obtain an accurate rating for the patient's usual performance. As I referenced earlier, this is so essential because a therapist Section GG score may be based off of 1 or 2 hours with a patient, whereas nursing, especially within the first 3 days, has a much more intimate relationship with that patient. Historically, we have relied on one or the other to provide the information, and it truly takes a team to ensure that all of this information is accurate for each plan of care. It will often fluctuate the first 3 days and should be recorded as such in order to get the most accurate representation of the patient's functional abilities. To improve outcomes within your facility, as well as reimbursement, it is essential to know what each therapy discipline is focusing on and treating. The plan of care for each discipline should be reviewed daily up until the ARD date and then continued in the weekly utilization review meeting. From day 1 until the ARD, it is important to focus on speech therapy's interventions with each patient. Often, a speech language pathologist will identify things such as cognitive or swallowing deficits that other disciplines will miss due to their specialized training in these areas. This will not only affect the plan of care for the interdisciplinary team, but could also increase reimbursement by $15 to $20 a day if captured on the MDS submission. Fourth and goal. So no one likes to be caught in a game time decision such as fourth and goal. This is why DC planning from day one is so essential in order to avoid these uncomfortable situations. It is vital for the interdisciplinary team to discuss both desired and possible alternative or realistic DC destinations for each patient to be ready for all possible outcomes of the plan of cares that are delivered. So reviewing the film. This is so important because without doing this, how do you know if your PDPM huddle strategy is working? In order to grade the success of your game plan and execution, a quality assurance review is essential. Following each MDS submission, communication provided during the huddles must be reviewed to ensure that all commitments and information shared made it to the MDS submission in order to be paid for the services that were rendered to each patient. For example, if the speech language pathologist discovered a swallowing symptom and provided treatment for this, we must ensure that it was recorded on the MDS submission. Without reviewing the film, it is difficult to judge the success of your game plan. TMC's Code and Integrity Division offers a team approach to ensuring each of our premier coding locations identify possible opportunities for increasing revenue through claiming all of the services they provide. In doing so, our premier coding locations have seen an $18 to $20 increase in average daily rates compared to other locations. For information on this service, please reach out to our business development department. Do just want to give a quick update on this. The restorative plan, I'm sure many of you noticed it, was a misprint that 5 times a week is qualifying. It is actually 6 times a week at 15 minutes for the 2 programs. And I just wanted to go, through a couple things. I know much of this information is things that we have known, even before PDPM as we prepared. However, in our experience, in many of the morning meetings that I have attended, it has become transparent that the communication and the structure of the meeting isn't where it needs to be yet. And using this game plan will really help improve that. And I think the over communication of each individual patient and what treatments are being provided and who's providing them is so essential for us to be successful. And I would challenge many of you to go back and do an initial audit and see how many times respiratory treatments were actually claimed on your previous MDS submissions. I think you would be very surprised. I know a lot of them will probably equate out to 0 just because we haven't got a good game plan and good communication on effectively claiming those treatments, although they are being rendered. Also go back and see how many patients you were able to capture RMPs on. Again, I think that is still something that is a working process for many of us, and the only way for us to really be able to successfully capitalize on that is ensuring that everyone on the interdisciplinary team knows that those treatments are going to be delivered and that they're being documented appropriately, and reviewing that on a day-to-day basis so that we can get better at it. Depression screens are another thing that I know we brought up here. I would challenge again to go back and see what percentage of your patients qualified for the depression screen to impact your overall reimbursement. As a company, we have seen an average of 35 to 40% of our total patients that qualify for that. And I think we can all relate that many of our patients will qualify during the depression screen because no one is in their normal state of mind, obviously coming into a sniff. That is a little bit of a downer, knowing that you have to come and receive those treatments, even if you are a healthy individual. So cognitive screens, again, that's a big piece to talk about. We see an average of about 50% of our patients that will qualify under the BIMS. I think one caveat to that is a lot of patients, they went through the BIMS at the hospital. Maybe you're giving it to them for the second time within the facility. Somebody else had asked them those same questions. And sometimes the memorization of those questions can make them appear cognitively intact when really, if we just alter the delivery of the BIMs a little bit, we could find a true grade of their cognitive abilities. And kind of along those same lines, look back at your speech language pathologist delivery and their treatment plans. If you find that you have patients that categorized in the PDPM category of SA, yet they were receiving speech therapy treatments, that's a good identifier that speech therapy had found something they could treat. However, given the PDPM category of SA, would show that those deficits they found were not captured on the MDS submission. So those are some helpful hints to get started to see if what you're currently doing is as effective as it possibly could be. And hopefully this game plan will help you make the adjustments that are needed to help both, again, outcomes and reimbursement within your facilities. If any questions do arise after this, please feel free to email them to the email address that's listed here on the slide, and we would be happy to get back to you with a response. So thank you all for joining today. It was my pleasure to provide you this information. We hope to see you guys on our upcoming webinars that will continue next month, and we look forward to hearing from you. In the meantime, our thoughts and prayers are with you as we continue to face the challenges of COVID-19. Thank you again. Stay safe and stay healthy.